Good afternoon, all. Today's topic for discussion is antimalarial drugs. Let's begin with the epidemiology. There are worldwide 216 million cases, and out of which there are 2 to 3 million deaths every year. So in India, there are various programs developed for the control of this malaria. For example, like National Anti-Malaria Program, National Malaria Eradication Program, National Vector-Borne Diseases Control Program. So malaria is a protozoal infection caused by the genus Plasmodium that are transmitted to the human by the bite of infected female Anopheles mosquito, and it is characterized by chills, rigors, and chronic progressive splenomegaly. In etiology, we have 4 types of Plasmodium. 4 types of Plasmodium species are there, out of which the first is a Plasmodium falciparum. The malaria caused by the Plasmodium falciparum, it is also called as malignant tertian malaria. And as the name suggests, it is the most severe form of the disease. The symptoms include the chills, rigors, fever, and chronic progressive splenomegaly, which may, if untreated, ultimately leads to the death. Second is the Plasmodium vivax. It is also called as benign tertian malaria. It is less life-threatening or rarely life-threatening. The pyrogenic threshold of this parasite is lower than that of the falciparum, and it predominates in Latin America, Pakistan, and India. The third type is Plasmodium malariae, which is also called as cotton malaria. It is very rare. The fourth is Plasmodium ovale. It is also called as ovale tertian malaria, and it is almost exclusively found in Africa. Now coming to the most important part of this malarial infection is the life cycle of the parasite. Coming to the life cycle, the Plasmodium has 2 cycles. One is sexual cycle and another is a asexual cycle. The sexual cycle occurs in the vector, that is female Anopheles mosquito, which is a definitive host, and the asexual cycle carried out in the human, which acts as a intermediate host. Okay, so in intermediate host, that means in the human being, there are 3 stages we found in the RBCs and liver. The first is pre-erythrocytic stage in the liver. Second is exoerythrocytic stage in the liver. Third is erythrocytic stage in the RBCs, that means blood. So let's move to the next slide so that the life cycle of this malaria infection will get clear. Okay, now we will discuss the life cycle of this malaria. As you can see, the yellow part, the pink part, and the blue part. Okay, the yellow part, it is a sexual cycle which occurs in the female Anopheles mosquito, as we have discussed in the last slide. Okay, and the rest of the 2 columns are there, which includes the asexual cycle which occurs in the man. Okay, next, when this mosquito, it injects the sporozoids when it bites to human, and when it is injected into the bloodstream of the human. When they are injected into the bloodstream of the human being, they release sporozoids, and these sporozoids get into the liver. So in here liver plays a very important role in the asexual cycle. The sporozoids get into the liver, they multiply asexually to form the merozoids. All these merozoids collectively called as schizones. All these merozoids, they are collectively called as schizones. After some time, this liver cell then burst out, releasing into the blood. In bloods we have many merozoites. They invade the RBCs and they multiply themselves. Okay, they infect the various they invade the various RBCs and they multiply there, and therefore there are many merozoites in the RBCs. Okay, some of them they form a ring like structures which is called as trophozoites. The ring like structures they called as trophozoites, and they multiply asexually to form many merozoites. When they release the merozoites, the cycle is repeated. We can see here the trophozoites, they form a schizogony, schizons, and they further release the merozoites, and further after the release of the merozoites, they further infect the RBCs, that is erythrocytes. This way the cycle is repeated, and after the release of the merozoites, the patient may experience the fever, chills, and sweating. So this is how the cycle takes place into the erythrocytes. After the several asexual cycle, they develop the sexual form of the parasites, which is called as male and female gametocyte. They are both found in the blood cells. Okay, they are both found in the blood cells. All these male and female gametocytes, they bite the human being. After the bite of the mosquito bite of the infected human being which contains this male and female gametocyte, the female Anopheles mosquito, they suck up the gametocytes. They form the gamete. This Anopheles mosquito form the gamete. After the formation of the gamete, they form the zygote, then sporozoites, and they reach the salivary gland of the female Anopheles mosquito, and after that they are ready to bite the another non-infected human being to release the sporozoites. Okay, so this is how the life cycle of the malaria plasmodium species occurs, which includes the sexual cycle in the mosquito and a sexual cycle in the man. Livers plays very important role in the life cycle of the plasmodium species, which includes the exoerythrocytic stages, pre-erythrocytic stages, and in RBC there are the erythrocytic stages. Now, coming back to the pharmacotherapy of malaria, we have various drugs for the treatment of the malaria. So, depending upon the chemical classification, that is based on the chemical structure of the drug, we have the classification of the drugs. We have the various classification of drugs. For example, like 4-aminoquinones, which includes the drugs like chloroquine, amodiaquine, piperacin. Second is a quinoline menthol, which includes the mefloquine. Third is a cinchona alkaloid. Example is quinine and quinidine. Fourth is a biguanides. Example is proguanil and chlorproguanil. Fifth is a diamidopyridine. Example is pyrimethamine. Sixth is a 8-aminoquinoline. Examples are primaquine and bulaquine. Next is the sulfonamides and sulfone, which includes the drugs like sulfadoxine, sulfamethopyrazine, and dapsone. The tetracycline antibiotics, which includes the tetracycline and doxycycline. Swescatripine, lactose, these are also called as artemisinin combination therapy. These are the most advanced drugs which are used in the treatment of the malaria. These are commonly used nowadays: artesunate, arteether, and artemether. Next, other drugs are the halofantrine, lumefantrine, pyronidine, and atovaquone. These are some examples of the drugs. Now, based on the affected plasmodial state, we have the different classifications. For example, like tissue or hepatic schizonticides. These are effective against the both forms of primary and latent tissue forms in the liver. For example, like primaquine like drugs. Second is a blood schizonticide. It acts on the erythrocytic stage, thereby terminating the acute attack, which is divided into two types. Fast acting high efficacy blood schizonticide, for examples like chloroquine, quinine, mefloquine. These are single use. And second is a slow acting low efficacy blood schizonticide. It can be used only on combination, for example like pyrimethamine plus sulfadoxine. Third type is a gametocide, which destroys the gametes in the blood, for example like chlorine, quinine for Plasmodium vivax, primaquine, artemisinin, pyrimethamine and proconil for vivax and falciparum. Now we are going to discuss the each and every drug one by one. The most important drug nowadays is chloroquine. So it included into the class 4-aminoquinolines. So chloroquine is a very potent and rapidly acting erythrocytic schizonticide against all species of Plasmodia. It has no activity on the hepatic stages. It has no activity on the hepatic stages or the liver form. Let's discuss the mechanism in detail. So chloroquine. Actually the complete mechanism of the chloroquine is not known, but the chloroquine, it actively concentrated by the intraerythrocytic plasmodia. They form in the acidic vacuoles of the parasite, which causes the rise in the pH, and it interferes with the degradation of the hemoglobin by parasitic lysosomes. Parasitic lysosomes. This parasitic enzyme heme polymerase complex, it is toxic heme, then it is converted into the non-toxic hemosynth. It also interferes with the biosynthesis of the amino acids which are necessary for the parasitic survival. Coming back to the pharmacokinetics of the chloroquine. Absorption, it is completely from the GIT. Large volume of distribution, more than 1000 liter per kg. Remember, the chloroquine has a large volume of distribution. It is metabolized into the liver. T-half is long because it's high concentration in the tissues. Initial T-half is 2 to 3 days and terminal it is 1 to 2 months. Side effects, short-term side effects, it has a mild headache, visual disturbances, gastrointestinal upset, for example like nausea, vomiting, pruritus, urticaria. If the bolus injection is given of the chloroquine, then hypotension and dysarrhythmias may occur. After the long-term use of the chloroquine, retinopathy characterized by the loss of central visual acuity, macular pigmentation and retinal artery constriction can occur. Lichenied skin eruptions, bleaching of the hair, weight loss, these are some long-term side effects. Let's see the contraindications. Renal failure, visual field abnormalities, porphyrias, and G6PD deficiency. These are the contraindications for the chloroquine. What are the therapeutic uses of chloroquine? Malaria, it is a drug of choice for the clinical cure and suppressive prophylaxis for all types of malaria, especially malaria species except that are caused by the resistant Plasmodium falciparum. If it is sensitive to the chloroquine, then chloroquine becomes the drug of choice for the clinical cure and suppressive prophylaxis. Second is a giardiasis. Third is a rheumatoid arthritis. Then extraintestinal amoebiasis. Discoid lupus erythematosus. It is very effective, less valuable in the SLE. Sixth is the lepra reaction, infectious mononucleosis. It affords the symptomatic relief in the infectious mononucleosis. Photogenic reactions. So, of all these uses, the short form is, for therapeutic uses, the short form is Mahatma Gandhi red lip. Mahatma M. Gandhi G, that is malaria, G for giardiasis, and red lip, red for rheumatoid arthritis, extraintestinal amoebiasis, D for discoid lupus erythematosus, R L is lepra reaction, I is infectious mononucleosis, and P is photogenic reactions. Okay, so you can easily remember this short form to if it is asked in the exams as a therapeutic uses of chloroquine. Okay, then out of the same class, the second drug is a amodiaquine. It is a container of the chloroquine. It is less bitter. I'm sorry for the spelling mistake. It is less bitter, and it is used in the chloroquine resistant falciparum malaria along with the artesunate. Okay, these are less commonly used. Piperacquine. The mefloquine is also synthetic quinoline methanol. It is fast acting erythrocytic schizonticide. Mechanism is similar to the chloroquine. It is used in the chloroquine resistant plasmodium species in combination with the artesunate. It is highly cardiotoxic and cause the QT prolongation.